Hello, everyone. Welcome to our session today. Welcome to another pre-health shadowing session. I will be going over a quick startup presentation to welcome you all and introduce you to our program and the various opportunities we have here at Pre-Health Shadowing. So if you didn't know, Pre-Health Shadowing is a student-led, minority-led, women-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources no matter their demographic status, abilities, or location. My name is Muntaha. I am a team member here at Pre-Health Shadowing and also the editor-in-chief. So I welcome everyone for attending today, and let's get started. So just a little PSA, we do have closed captioning for all of our sessions to accommodate all students. This setting is available on the bottom of your screen, so if you do need assistance with enabling the transcripts, please direct me or one of my team members and we'll be happy to help you. But we do look for ways to be more inclusive, so if you have any recommendations, please email us at the info@prehealthshadowing.com. So since this is an international program, we want to know where everyone is Zooming from today. Please drop your location in the chat. I'm calling from Florida. It's really nice that we have so many people from across the country, and we have a lot from Los Angeles. That's cool. So we have some wonderful opportunities for you as being part of the program. But before that, we like everyone to stay in the loop. We have our Instagram, our TikTok, and you can also sign up for our email list just to keep track of all of our sessions and to never miss a session. We have partnered with Kaplan to get our students a 10% discount code that can be used on all Kaplan products, as well as free resources such as study guides to help prepare you for standardized tests like the MCAT, NCLEX, or PCAT. So if you do fill out our short survey in the chat, you will be signed up for these deals for absolutely free. We would also like to draw your attention to another amazing program at the bottom of the screen called Neolith. Neolith is an online mental health program for students, for pre-health students especially. We know that the path isn't easy and can be stressful. So that's why we've partnered with Neolith to spread the word about their mental health program and offer free access to their services if you use the link in the chat and enter the code PREHEALTH when signing up. Another partnership we have is Mask for Mask. It's an amazing women-led organization that donates 4 masks for every 4 masks they've sold. So these masks go to people in need during the COVID-19 pandemic, like the people in the homeless community, healthcare workers without proper PPE, and others who are just struggling to stay safe during the pandemic. So if you'd like to donate and have some cool masks for yourself, please visit Mask for Mask, and with our discount code PHS15, you will get a 15% off from your first order. If you buy through this method, 10% of the proceeds actually go to PHS, which is amazing because we are a nonprofit that runs solely off the support of our community. You can go on to buy your masks at the link in the chat. If you want to play a bigger part in supporting PHS, we would love for you to join our network of student volunteers and team members. You can apply to be part of our administrative team and lead students in various projects, initiatives with professional outreach, grant writing, and so much more. We understand that as pre-health students, you may not have the time, so we do offer another separate opportunity in which you can volunteer asynchronously with tasks that can be done on your own schedule. We would love to have you be part of this program and contribute to your unique perspective. If you are a high school student and want to get involved, we have started a program called HTP, which stands for High School Training for PHS, which allows you to connect with college pre-health programs, get involved in fundraising for PHS, and organize resources for other high school students. It's basically a preparation for anyone who's interested in medicine but still in high school. We want to recognize the hard work of all of our students in the program. So if you'd like to get published, you can write articles, reflections, reviews of our live sessions, and success stories. This will look great on CVs, and since I'm the editor-in-chief, I look forward to looking at any submissions you'd submit. The link is dropped in the chat if you'd like to submit an article, reflection review, or success story. So as a part of our mission at PHS, we do like to promote diversity. In order to do this, we have launched an initiative to have monthly panels to celebrate different demographics in the field of medicine. Some of these upcoming events include a series on patient experiences, a COVID-19 roundtable, international student forum. So if you have a mentor, professor, or a professional that has inspired you and you think they can contribute to these conversations, nominate them today using the link in the chat. If you can, we humbly ask that you donate to our program. As you know, pre-health shadowing is completely student-run, and we are working around the clock to keep this free and accessible to everyone. Unfortunately, Zoom and our website are not free, so any contribution you can give would be greatly appreciated. If you are not financially able, we request that you send this link to someone who you think can contribute, and just spread the word about pre-health shadowing so we have a lot of students joining our session and getting the education they deserve. Throughout the session today, we encourage you to drop any questions you have for the speaker in the chat. Our team members will be making note of these, and we are going to be asking them to the speaker at the end of the session for our 30-minute Q&A. If you'd like to unmute at the end and ask questions yourself, you can definitely raise your hand and wait till the end of the session to ask. Take good notes as our professional is going over their presentation, as there will be a chance to take a post-shadowing assessment. This is done to verify your virtual shadowing hours, and it will be on the information the presenter presents during her presentation. So more information will be available on this at the end of the session, so stay tuned. Lastly, if you can, we request that you turn your cameras on. This is by no means an obligation, but it does help us feel a little closer together in a time where we have to socially distance. So if you'd like to turn your camera on, I appreciate you for listening. And now I would like to welcome our professional, who is a gastroenterologist, Dr. Laster. Thank you so much for joining us today. If you may share your screen whenever you're ready.
Awesome. Thank you for having me. So great to meet you all. I'm going to share my screen now, and hopefully this works again. Perfect. All right. So I was asked to talk about gastroenterology. And so they said, why gastroenterology? And I could stop right there and say, because it's the best field. We could just move on for the night. But we'll go to a little bit more detail. I'm a little bit more self-specialized, and we'll talk a little bit about that, in which I also do obesity medicine, bariatric endoscopy, and nutrition. And so we'll talk about a little bit about how I got there. First, I wanted to ask a couple of questions. If you guys could drop it in the chat, just so I can have an understanding of sort of who's in the group. What current year are you guys in your training? Let's see. Where's the chat?
I've launched a polling.
Oh, I see it.
Polling
Awesome.
question, so we can see where people are from in the United States or outside, and definitely what level of training.
Perfect. Awesome. All right. And how do I move this over? No. All right. And I also want to know how many of you guys have already applied to medical school, and how many of you have a physician mentor? Let's see, what do we have here? All right, Northeast US, Northeast and Southeast are the most. Western, Midwest, and outside the US, awesome. So we have some high school students, some seniors and postbacs, and masters and PhDs, awesome. All right, let's see, I guess I should go back here. And how many of you, is this one of the questions you have already listed in your poll as well? How many have applied to med school already?
No, we don't have that on our poll.
Okay, no worries. And then some things to keep in mind are whether you already have a physician mentor, and if you're following Med Twitter, which we'll talk a little bit about later too. So a little bit more about gastroenterology. The way I sort of explain it to my patients is anything from the mouth to the anus is your entire digestive tract. So when we think about the esophagus, the stomach, the small intestines, the colon, and the rectum, we also think about things that are outside of the GI tract, but also help with digestion and other kind of digestive function as well, like the pancreas, the gallbladder, the liver, the bile ducts as well. So these are all things that sort of fall under the realm of gastroenterology. And so it's a sort of a detailed sort of understanding and of the physiology of the GI organs, sort of how things and food moves through the stomach, intestines, and colon, the motility of those things, the digestion, digestive enzymes that also interplay from the gallbladder, from the pancreas, what happens in the common bowel duct, how you form gallstones. And these are all things to sort of work together to make sure we have proper functioning. Some common conditions that are associated with gastroenterology are colon polyps and colon cancers are probably the highest, most common. Then there's things like hepatitis, GERD or heartburn, peptic ulcer disease, and people say they have sort of that gnawing dyspeptic pain in their stomach. Things like a kind of a nondescript symptom would be colitis, which we see on imaging sometimes. You can also see inflammatory bowel disease like Crohn's or ulcerative colitis. There's gallbladder disease as well, gallbladder cancers, biliary tract diseases where they have stones that get stuck in that biliary tract. There's also nutritional problems and problems with absorption. And pancreatitis, whether that be due to an autoimmune pancreatitis or alcohol or smoking. And then there's sort of things like irritable bowel syndrome, which sort of have an entire kind of grab bag of things like abdominal pain, bloating, nausea, vomiting, and changes in bowel pattern like constipation or diarrhea. So pretty broad field is what gastroenterology is. And we also subspecialize into some of these things as well to sort of kind of narrow it down a bit. So I want to start a little bit about sort of where I started. And so we can sort of follow my crazy journey to let you know no journey has to be a straight line. I grew up in Birmingham, Alabama, and it's sort of an interesting trajectory for me because of sort of the foods we eat in Alabama. And I saw a bunch of people from the South there too. So as you know, most things are in butter and oil and fried and greasy. If it's a part of a pig, people are eating it. And it's not a lot of fruits and vegetables all the time. And as I grew up sort of in my family, it was far more garden in a neighborhood, which I thought was always super weird. I thought my parents, I called them tree huggers growing up. I'm like, oh, this is so weird. We're the only people with this. Why can't I have the Lunchable that everybody else has when we go on a field trip? And having a garden, which fast forward to me being in nutrition later is, now they make fun of me. And so after leaving, going to college in Atlanta, Spelman College is a historically Black college for all women, located in Atlanta around in a consortium of many, many other colleges. And during this time, I was a psychology pre-med major because I was fairly certain I would be a psychiatrist. And so really enjoyed psychology and did sort of all the pre-med courses just like you all are doing. But was not a science major, so I was a little bit intimidated by that. And so I did a summer program during my junior year, I think, or senior year maybe. And it was junior year at UAB in Birmingham. And it was a mini medical school program to sort of get me over my nerves of not being a hardcore science major and taking a bunch of science classes together. I was afraid to sort of apply to med school. This was sort of helpful for me to sort of make sure I could handle the load because I didn't know if I'd be able to. But I was also a crap test taker. So when I took the MCAT for the first time, I said, oh God, I need to find a new career. Apparently this is not for me. But then decided, okay, let's try this again. Let's do a post-bac program and actually sort of put my head down and focus and learn about test taking because the information is there. I need to know how to test take. And that's what I did at American University in Washington, DC, did a post-bac program, reapplied to medical school with much more confidence this time and took the MCAT and voila. Then heading to Texas, which if you are from that part of the world, you know that Texas has their own sort of application process that is different from the regular, I think it's still ERS, I think that's what it is, application process. And so it's hard to sort of break into. And to think about medical school, the first 2 years are typically when you're in the classroom. You do some rotations into the hospital. And then after your second year is when you take one of your biggest tests, which is your step 1 exam. This test we'll talk a little bit about later because that sort of is what kind of gets you into your residency programs of choice. And then what I talk to students about a lot is during college and prior to med school is sort of getting as much exposure as you possibly can. Because in those first 2 years, in that beginning part of that third year, you're really expected to make a decision on what type of specialty you want to do. And that's when you start doing preparing for interviews during your fourth year of medical school. And you may not have finished all of your rotations at this point. You may not have even had the chance to sort of see some things yet. So, for example, emergency medicine is one of those things people tend to do later. And if you have never shadowed and been into the emergency room, you don't know that that's something that you may actually really like. And it may, you may sort of be off kilter there a bit. So I talk to patients and students a lot about making sure that you're able to shadow and see as much as you possibly can, even if you're in high school, while you're in college, sort of seeing different types of fields of medicine. And at the beginning, as I told you, I thought I would be a psychiatrist. And then I had a mentor who was also a dermatologist. And so I was open there too. And so seeing many different things allows you to sort of see what works for you. And then during your fourth year, you go on your interviews, and then you take during your fourth year, you also take your step 2 in CK, which are 2 additional board exams that you take. Let's see. But very important, even once you get into medical school, is continuing to do research, continuing to be involved in groups on campus, continuing to find what your passion is within medicine. Because these are things that are going to also be important when you're applying to residency and down the line for fellowship as well. The next thing is, students ask all the time, how in the world do I choose? You just told me the first 2 years that we're mostly in the classroom and doing sort of, more book work with only a few rotations here and there throughout those first 2 years. And really expecting to make a decision pretty early on. So, and one of the things I talk to students about is being very open-minded. I found a lot of people that went in and said, I can only do this is what I'm doing, and having a lot of tunnel vision, only to get to the end to realize, oh man, maybe I did like this thing a little bit more. So being very open-minded, paying attention on your rotations to people's lifestyles, how they treat one another, what is the general personality of that sort of specialty. I found that I love trauma surgery. I love the idea of the helicopter coming in and the excitement that you got when the pager went off as a student and what are we going to have next? It's going to be so much fun. I love that. But I also recognized, I told one of the trauma surgeons how much I loved it. And I said how exciting the helicopters were and all of the stuff and patients are coming in. And he goes, you know what, at 55, let me tell you, the helicopter is not so exciting. And so it just pay attention, make these connections, talk to people a little bit more. Because after he said that, I'm going, you're probably right. I probably will have seen so much at that point. It won't be so exciting. Is it when you're a third year student, you hear the helicopters like, yes, I get to see something else crazy happen. But it's really important to sort of see sort of what the field is for that specialty. And as you start going through rotations and meeting more people, you start to notice that every specialty, they're very common. We joke in GI that everybody is super laid back. We all procrastinate. And so every year before our big conference, which is DDW, we're all submitting all of this research, and every year the site always crashes on the night that everything is due. It's because we all wait to that very last night, right before it's time to submit. And so we always joke about all of our personalities. So pay attention to the rotations you're on and finding people that are similar to you. Pay attention to what you like and you don't like. There's nothing that says you have to do a particular specialty either. And be true to yourself. I have a little bit of ADHD, so GI is perfect for me. I'm able to do clinics some days. Some days you have patients that have emergencies when there's vomiting of blood, so there's a little bit more heart pumping there. You get to get a little bit of adrenaline going. Some days they're just routine procedures that are outpatient, like a routine colonoscopy. And there's a lot of mix in between, a lot of variation. So it's really hard for me to get bored, which is something I wanted. I didn't want to do the same thing every day. Whereas I have a bunch of friends that are, rheumatology, internal medicine, that do mainly clinic work, or patients that do mainly hospital work. I like to have sort of a little bit of all those things. So it's hard for me to sort of get bored. So these are things to try to take into account of how sort of what you like. And then there's the famed match day that tells you where you're going for the next 3 to 4 5 years of your life. And every medical school is a little bit different, where you kind of, everybody gets their letters to figure out where they're going. And this is from my match day many moons ago, but our lovely med school continues to post this on their website every year. So I get to be embarrassed every single year by my insanity on match day. But so that was the next step, is once you decide where you want to go, the next step is deciding what specialty you decide, sort of where you want to go. And for me, my first choice was Georgetown for internal medicine. Why internal medicine is because to me, it felt like the quintessential physician. So, they were the smartest in the hospital to me. They knew how to take care of sort of everything. It was sort of, it was a very empowering feel. I love how the people thought on rounds. I love the thoughtfulness. I like the idea of being able to sort of fix everything. And I also like that there are so many options beyond internal medicine as well. So there are so many opportunities for specialties. And even during my med school, I started to think, I think I want to do procedures. I liked surgery, but I don't want to wake up every morning and be in the hospital at 3, 4 a.m. But I also want to be able to do some procedures. And so GI was sort of that mix for me. And so when you go to your residency, wherever the residency year to choose, it's still that same sort of process as well, when you still have to sort of pay attention to what type of specialty you may want to do, because it's the same thing where you have to apply pretty early on so you have to have been doing research as well. And so it's a lot of research you're doing during med school, during residency. You are kind of following it to see what those specialties are about. You're going to those conferences during the year, the national conferences. You're learning more and more. Sort of kind of how you start to understand which you think may be sort of a good fit for you. And under internal medicine, there's cardiology, gastroenterology, what do you see? Nephrology. There is endocrinology, infectious disease. I'm missing one of my pulmonary and critical care, hematology and oncology. So the sort of endless things that you could do after you do your internal medicine residency. So during those 3 years, first year you take another exam, your step 3 exam. Then second year, you apply for your fellowship. And third year is when you're finishing and going to move on, and then you take your internal medicine boards. And then for me, it was gastroenterology fellowship. And many people say, what in the world do you do during fellowship? And the biggest thing for fellows is learning how to do procedures, colonoscopies and upper endoscopies, which is sort of the bread and butter of the field. And many people ask, what do you see during these procedures? And patients are sometimes confused and ask, can I see your liver? Or did you see my liver doing my procedure? How does it look? Did you see my prostate? And so you have to remind people of what's in the GI tract and sort of what is in the realm of what we can see. So I hope this video works. There we go. So this is a video of showing okay, here we go. Let's go back here. And I can mute him so that I can tell you what we're seeing. All right, so what we see here is you start in the rectum. And as you can see on the right is showing you sort of how we're going through the colon. So if you imagine at the left side of your belly, that's where the scope is going first. And making its way up through the transverse colon, all the way down on the right side of the colon, on the right side of your belly is where we are with the scope. And we know we are reaching the end when we see something called the appendiceal orifice. And beyond that, it's what's called sort of the terminal ileum, which is getting into your small intestines. And this is, everybody's colon is a little bit different, but this is a very clean colon, as we like to say. So people say that GI is a dirty job. I can't believe you do that. And as you can see, it's not dirty at all. If somebody is dirty, that means you won't be able to see, which is the whole point, is to be able to look for small polyps, remove them, look for changes in the mucosa that make us suspicious for inflammatory bowel diseases like Crohn's ulcerative colitis. We're looking for any sources of bleeding. We're looking for ulcers. We're looking for sort of any sort of small changes in the mucosa that can cause people to have symptoms or be precancerous. And there's a lot of twists and turns, as you can see, sort of getting through the colon here. And so this is where we're getting here is where the actual appendiceal orifice, which tells us we're at the end. We've made it to the end. So it's called the cecum. And as you can see, the hand movements that you're using with the scope is on the left there. And so we talk about patients being very clean a lot. And so you have to take it in. The worst part of a procedure is the prep they take the night before. And so it makes you have a lot of bowel movements to get this as clean as what you see here. Sometimes we have to spray water, as you see they're doing there, to be able to clean it up a little bit more to take a good look of sort of what's going on in the colon. And so as we go in, we're putting in air. And now as we start to come back is when we look for polyps. And we sort of use air and water to sort of keep the colon nice and distended. So you're able to see all around every sort of angle. And that's what a colonoscopy looks like. It's simply looking, starting at the rectum, going to the descending colon, transverse colon, ascending colon, and the cecum. And that is the fun of a colonoscopy. The next thing we'll talk about is an upper endoscopy, and this one I couldn't get to play here, so maybe I'll get it to play here a little bit better. All right. So this one is, I'm going to try to make it a little bit shorter because it goes really long. So this is the esophagus. So when you go in through the mouth, you know, there's two pipes. So person sharing is paused. Can you guys see this?
Yes, we do.
Okay.
No, not right now.
No? All right, something about something is being paused here. Not sure why. Sharing is paused. Bring your shared window to the front. Oh, it's not letting me show the video here. That's why. Maybe if I stop it and share, haha, there we are. Is it working now? Are you seeing a video?
I see it. Oh, there it goes.
All right.
Yes, we can see it.
Perfect. All right. So this is, I'll back up a bit here. So this is when you go in through the mouth and you're into the esophagus, you're just moving down. And as you can see, you're having some contractions. And so that's sort of how the mucosa is able, food is able to go down. You have like little contractions in the esophagus that are occurring. This person has a hiatal hernia, and we can see how the color changes from a really pale pink to a little darker pink. And something you may be learning in your pathology classes are things like squamous epithelium and columnar epithelium. This is when we see the change on the mucosa of the esophagus to the stomach. And sometimes we can see some cancerous changes if you see too much of that change, called Barrett's esophagus. And this person has a little bit of a hernia where they probably may have a little bit of acid reflux, as you can see, as that change is sort of up in the esophagus a little bit higher than it normally is. And then we go down through, did I go too far there? And now we have to sort of go into the stomach, and those rugae we talk about are folds that are in the stomach. When we eat those rugae or folds are able to open up to accommodate you eating more food. And then we sort of go around the corner, and that little hole at the bottom is called a pylorus. And this is sort of a lever that allows food to sort of empty the stomach into your small intestines to sort of start to continue with digestion, to allow you to accommodate more food. Then we're going to go into the small bowel. And I feel like a fellow did this because it takes a long time for fellows to get into the pylorus sometimes. But, and then when you get into the small bowel, you're able to see, it looks like a little bit bumpy. You see, it looks a little bit furry when you look a little bit closer. Those are the villi, and that's what helps with absorption of food. And so still here, you have sometimes people come in with bleeding or melena, which is dark stool, and we think of bleeding in the upper GI tract. And this is where we go and we look very carefully to look for any ulcers to see if we need to treat them. And sometimes you also may see signs of celiac disease or Crohn's disease with changes in the mucosa in the small bowel as well. And then you come, that's like further down in the small bowel, and then we come back into the stomach. And you see there's kind of more distended now as we put more air in. And then next what we do is we turn the scope on itself, which is called retroflexion. And this is when we're looking for anything that can be hiding in the top of the stomach that we couldn't see on the way in. And so this sometimes you can see what are called esophageal varices or gastric varices that we can see with patients that have cirrhosis. And this is sort of how we look at that to get a better look at it. It's really turning that scope all the way around. That black thing is the scope there that you can see. And it's really pulling down to make sure we didn't miss anything in that top area. And that is an upper endoscopy. So now let me go back here. All right, I think we're back, right? All right. And then people ask, so how are we taking polyps out? What's a polyp? And so a polyp is a precancerous lesion that can be in the colon. And as you can see, they're pretty small usually when we see them. They're not normally very big. And that's why we have patients to come in for screening. And that's what the whole reason for a colonoscopy. We want to make sure that these polyps do not grow into cancer. So that's what happens over time. On the still images to the left are larger polyps. And we want to make sure that these polyps do not continue to get bigger. They don't spread throughout the mucosa and become metastatic. And patients also wonder sometimes, is this going to hurt? Am I going to feel it when you take these polyps out? And the answer to that is no. People would wake up and not remember it all. And there's several sort of techniques that we use to take out these polyps. And one in this video is sort of a lasso sort of approach. And the next one is coming up soon here. And it's just called a cold snare. Sometimes if it's very big, we'll use a hot snare. And so you can see the polyp here, and that's sort of what's called the snare you see coming out of the scope. We get it all the way around the polyp and tell the tech to hold it tight and cut. And then we're able to retrieve that snare back into the scope. We go right up to where we just cut and suction it to the scope. And the scope is attached to what's called a trap. And we're able to send that to the pathologist to review it. And it's very simple to sort of cut through those polyps. Patients don't feel them at all. Sometimes if there are larger polyps, we have to do sort of a little bit different technique than what we just saw here, but sometimes it's sort of injecting it with water or putting some cautery, so heat around it to make sure they don't bleed afterwards. But for the most part, patients have very small polyps, you don't feel them, and we base your family history and the pathology of the polyp on when we need to have you come back in for a repeat colonoscopy. And that's because patients that have a family history are at increased risk themselves. And also, once you've had a polyp, you're at risk for having additional polyps in the future. If it's a person that has no family history, no polyps on their first colonoscopy, we get to stretch them out for 10 years so they can follow back up in 10 years. But if it's a person that has a family history, a history of polyps, a history of some type of genetic syndrome, like a Lynch syndrome, which puts them at higher risk for cancers, then we make sure those patients come back more frequently. We want to make sure that we catch those polyps before they become a cancer and we're able to remove them. All right. And now we've made it through the 3 years of fellowship. And so what do we do after fellowship? And so this is hard at this point because it's so many other options. It's for medical school, things are the decision sort of made for you. For residency, the decision is definitely made for you for the computer with a match program. For fellowship, it's the same system. It's a match system in which you put your information into a computer. The programs look at you. They decide they want to offer you an interview, but then at the end, they both rank. You rank and they rank. And it's figuring, and the computer shoots it out on the day of match day to tell you where you go again. So this is sort of the first time in the past, 8 years or so that you've had to make this sort of decision. So it's a big decision on whether you're going to do more training with an advanced GI fellowship. So we talked about some of those other options in gastroenterology beyond your general gastroenterology training, like an IBD fellowship, inflammatory bowel diseases, which is Crohn's or ulcerative colitis. Another advanced fellowships are nutrition. Advanced endoscopy like ERCP and EUS, looking at the biliary system and the pancreas. And there I have nutrition twice. Bariatric endoscopy, where we're doing endoscopic procedures for weight loss. And there's also transplant hepatology. So there's several other kind of advanced GI fellowship positions that you also would have been applying for during your second year of your GI fellowship in order to go on interviews through your third and know where you're going at that point. And then the other options are fleeing the nest and going into private practice, but it becomes difficult because you don't know sort of what you want to do. You don't know anything about private practices. You've never been there. So again, during your fellowship is doing that research, making sure you keep in touch, making sure you go out and you sort of see sort of how things are working in the real world. Another thing that you already know is the academic medicine piece. And so staying in that environment. And I did something completely different because everyone thought I was insane. And so this is something called locum tenens. And so I knew I wanted to do nutrition training in bariatric endoscopy, which is going to take some flexibility. And locum tenens is just for that, it's flexibility. And so it's usually in areas that don't have enough specialty physicians like gastroenterology. And they have short-term sort of stays where they need coverage in those areas. So I was able to go to several different areas around the world and sort of be their shorthand coverage of sort of bridge that gap for gastroenterology care. And these are just certain companies that are allowed to help you with that. And it's actually really nice, and some of those things that I talk to a lot of physicians about when they're coming out, to give you that little period to really make your mind up and not to make a rash decision, get into a contract for a place you hate, just because you don't know as much. Locums gives you the option to be able to see different practices, see how things work, and give you an idea of sort of what you like and what you don't like. They pay for your travel, they pay for your rental car, your hotel, all this other stuff. And so it's sort of a nice way to sort of put your feet out and see what's going on, make money and actually practice, but then to see where you want to end up and what actually works for you. For me, during that period of time, I knew I wanted to use it so I can have say over my schedule so I could do sort of further training. And for me, that was a clinical nutrition fellowship, which was sort of an unorthodox fellowship in which you spend half of your time at OHSU in Oregon with a surgeon, Steve Bob Martindale, and he's also a PhD in nutrition. So most of his surgical approaches are very much based in sort of nutrition training. And also at University of Louisville with Steve McClave, who is a sort of a big time gastroenterologist in all that does a lot of J tubes, which are feeding tubes into the jejunum, and G tubes, feeding tubes into the stomach as well. And so being able to learn from these giants really sort of changed how I thought about medicine and how I wanted to provide medical care. So it was a great opportunity for me, and something some education about nutrition that I wish I'd had, prior in my training, that I think helps with me being able to educate my patients and counsel my patients as well. Let's see. In between that, the other reason I needed flexibility was to take additional board exams. So most people only take their internal medicine board exam and their gastroenterology board exam. But for me, I knew I wanted to have a career that incorporated obesity management, nutrition management as well. So I had to take the time to be able to be eligible to sit for the American Board of Obesity Medicine. So there's a bunch of requirements I had to do and lectures I had to go to sort of have enough credit hours to be able to take the exam, and then the nutrition specialist exam as well. And then the next thing I did because my other interest is bariatric endoscopy, and that is sort of bridging that gap and bringing it all together for me. So being able to provide not only my GI sort of background, but also taking it that step further to treat all of those GI diseases. Most of those things are going to require some nutritional recommendations. And so I was able to use that information from my fellowship and also that obesity medicine information with the pharmacologic therapy for obesity management. But also because I'm a proceduralist, I wanted to be able to do procedures as well that can help patients with weight loss. Some people are not at the point where they want to have a bariatric surgery like a gastric bypass or a gastric sleeve, but they want to do something in the middle that's less invasive, they're going to wake up without incisions, and they're also going to be able to have that extra help for weight loss. And so I thought it was a nice intermediate and a thing that is sort of on the rise here. I was able to train with sort of an expert in bariatric endoscopy in Madrid, Spain. And that's the guy in the middle in this picture here. His name is Gontrón López Nava. If you ever read papers in bariatric endoscopy, you'll see his name written all over the place. But it was an incredible experience. And so I'm going to show you a couple of videos about some of those sort of advanced procedures in gastroenterology. And the first one is the intragastric balloon, and you'll see sort of a presentation of the scope going into the stomach like we saw before. But this time the difference is we're not just looking, we're going to insert a balloon and fill it with fluid. And so that's what we're going to look at here. And so we have that scope going down into the stomach. We're also inserting that balloon inside as well. And we take the sheath off of the balloon as we fill that balloon with 500 cc's of water. And that balloon will be about the size of a grapefruit sitting in a patient's stomach. We'll leave it in place for 6 months. And during that time, you're being taught about portion sizes, labels, nutrition, sort of what is a well-balanced meal. And this is a kind of an evidence-based approach. And the reason this works, it works several ways. The balloon is in place, so it's space occupying. So you physically can't eat as much as you used to because it's taking up so much space. And this is helpful with my teaching in our teaching in clinic because it's showing you don't need as much as we typically are sort of programmed to think that we need to feel satiation. And when people overdo it, which everybody does because they are not used to slowing down to eat, they're not used to considering how they feel before they finish a plate. They get a little bit bloated, they get a little bit of nausea, and they feel horrible. And this works to sort of have a positive correlation with the brain so you won't do it again because you remember that feeling and you don't want to have it again. The other way it works is it slows your motility. So we saw that pylorus, which was the exit out of the small bowel in the last slide. And this sort of sometimes, because it moves by gravity, it's exiting that exit out of the stomach. And that by having that in place, you have food sit in the stomach longer. So people feel less hungry in between meals as well. So you leave it in place, like I said, for 6 months. Maybe have the patient come back 6 months later, we're able to do the same thing, take that scope, put it down, able to punch a little hole inside of that balloon, and then we drain all of that liquid out of the balloon, and then we're able to simply bring it out of the mouth, out of the esophagus, then out of the mouth. Typically, patients lose about 15% of their 10 to 15% of their total body weight, and they're able to keep it off because we've been instructing them about sort of weight management during that entire time, and portion sizes and control, and switching from those unhealthier options to healthier options of things that they actually like. The next procedure is called an endoscopic sleeve gastroplasty, and that one's a little bit different, and we'll show you sort of that during, let's start this now. And so what you see is we are using a device that has a suture on the end this time. So we same type of endoscope, but we changed the device, the equipment we put on it. And we're able to suture the stomach, as you see here. And we just sort of start at the bottom of the stomach, and then we start to suture across. And then we're able to, after making that last suture, we're able to drop the needle just like you would do in surgery, and then cinch that area of the stomach closed. And we repeat that a couple of times, as you see here. And that sort of gives you sort of, you see the stomach sort of zipping closed. So giving you the shape of sort of what you would see with the surgical sleeve, but only being done by endoscopy, which is pulling that gastric mucosa towards you. And we repeat that about four to 5 times to make a much smaller stomach. And as you can see here, the stomach, we normally make it a little bit smaller than this annotation. So it's about 1/3 of the size that it usually would be. And so that procedure works a couple of ways as well. First, that you are normally when you eat, as you saw when we opened that first, we looked at that last image, you have your stomach looks a little scrunched down, but once you eat, your stomach is allowed to accommodate and to allow you to have more food. But with those sutures in place, you're not able to do that as well. The other thing that happens is you're decreasing your ability to have that motility. So for things to sort of move out of the stomach into the small bowel and allow you to keep eating. The other way it works is that we use sort of hormones to our advantage. And one of those is ghrelin. And ghrelin is the only hunger hormone that we have. And that's secreted by the top of our stomach up here at the top, which is called the fundus. And we've changed how we do the procedure a little bit now in that we leave that part in place as a little pouch. And that's because if food is sitting there as it will, because it doesn't have anywhere else to go, we're able to send that signal to the brain to flip that switch off to tell you, oh, we're not hungry. We don't need any further food because the ghrelin is saying we have food there. And so we use several different ways to sort of make sure that that procedure is helping with weight loss and to feel satiated. So you're not eating so much during those meals and you're staying full much longer because you have that slow motility. So this is that next step of sort of what's called the bariatric endoscopy. And then that's taken full circle for me in that I wanted a little bit of the best of both worlds. I wanted to be able to do research, but I also wanted to be able to provide these procedures, which are newer and not done at many centers. And I also wanted to still be able to work with fellows and sort of do everything. And the problem for me was in private practice, they wanted me to do just to focus on sort of general GI and academic medicine. They said, well, why don't we do a little bit of everything? And so I, of course, wanted to just do it things my way. So that's one piece of advice I would say is finding what you want and being true to yourself to sort of figure out what we need. To figure out what works for you and what works well. And so this is my practice, Gut Theory Total Digestive Care. And I'm able to do sort of all the things that I found throughout my training that works for patients, which is nutrition training and nutrition education that's evidence-based for patients, in addition to pharmacologic therapy to help with weight management. And then that step further with those bariatric endoscopic procedures in the patient population that needs them. And what is my day to day? Day to day for most gastroenterologists, especially now, are telehealth appointments, in-office appointments. Some patients, some gastroenterologists take call at hospitals. So if there's emergent patients, they do those on weekends or on night calls. There's also consults in the hospital as well. For me, I also do bariatric endoscopic procedures in addition to sort of your routine upper endoscopies and colonoscopies for screening for colon cancer. For me, that other piece that I wanted is to be able to do research and publications as well, to continue to sort of kind of give back to the community and to be able to share the work and things that we see on a day-to-day basis, because this is what kind of helps to drive medicine and innovation. I like to keep myself busy. I'm also the upcoming textbook for nutrition, because as we talked about before, you don't get a lot of that during your medical school or your in residency training. So wanted to be able to give that to sort of the fellows and students. And so we're in the midst of finishing a textbook. Also in the midst of doing a gastroenterology fellowship nutrition curriculum that we're doing for a couple of fellowship sites as well, to sort of give that extra piece of education that's sort of missing. I work part-time at Eastern Maine Medical Center as well, and assistant professor at GW, George Washington University here in DC. Also like to do some medical advisory boards as well, and I own my own business, of course. So these are sort of, so your day in GI can vary greatly based on sort of what is sort of on the list for that day, whether that be routine procedures or be, working on the textbook or meeting with advisory boards or meeting with students or fellows, or just seeing patients or doing procedures. So sort of range from day to day, and that's what we talked about before, and making sure you recognize sort of what you like. And so that way you can sort of set your career to be that, so you don't get burned out like you hear a lot about sort of in medicine. And so some of my tips for med students would be to always be curious, always think, always have questions. And if you have them, ask them. Just always sort of push yourself to think about why. Why is this way? And to look for those answers as well. I also would say be well-rounded. There's nothing, you have to be able to do something outside of medicine, right? Your whole life can't just be medicine. So I think giving yourself that break and being able to have other things that you like, that you're going to enjoy, because you're going to need those things when you're working so hard as a med student, so hard as a resident, a fellow. There's a lot of work that you're doing. And so you need those outlets to have some downtime. That was when I started that program. Well, I was in medical school because there were actually 2 suicides at my medical school. And my medical school was not, a high stress medical school like some of them. And so this was sort of an awareness, and I was seeing it so much around the country during those years. It was, sort of scary that you would see that. It just went to show that there was so much focus on work, that there's no room for anything else to take care of your mental health. So I think that's very important to be well-rounded and to do other things outside of medicine, and find those passions outside of medicine as well. And also making sure that medicine is for you. Medicine is a long, long road to be doing for someone else, because your parents think you should do it, because your family thinks you should do it, because it's your idea of a thing to be successful. You really have to do medicine because you love it. It cannot be for anyone else. It is too much work. It's too much of a large part of your life, to do it for someone else. And so I think that's a hard question sometimes. And I've seen friends that, we made it to the end of med school and they say, oh, thank God, now I can just be done and get my degree. I have no intentions of practicing. And, because their parents were physicians, or because they were told it's what they were supposed to do. And these people don't, you really, one of those people will be great doctors and will care for patients, because a lot of the times there are things that are after hours, things that you're doing that are really beyond the pale sometimes, and really take over into your personal life sometimes. So it really has to be something that you love and something that you're going to give your all to, and not for anyone else. It is, when you're studying as many hours, when you're missing out on certain things, and that you're not able to attend or go to and making certain sacrifices, you want to make sure it's a sacrifice that you want to make. Always ask questions, always engage. Let's see, get experience. Always ask about shadowing to see different specialties. Don't just stick to one thing, make it a variety. And it's a lot easier now as well with Twitter and Instagram. It's very, very easy to interact with people and find people that are sort of like-minded. Ask about research. Residents and fellows love when they have a student that also wants to help out and sort of be able to collect data and that sort of thing. But you learn about the process and you're able to get published early on, which are all very helpful for applying to medical school, residency, and fellowship. Attending virtual seminars. Although COVID brought about some crazy, it also brought about more opportunities as well to be able to attend virtual seminars, virtual lectures, virtual conferences, and following people on Instagram and Twitter. I asked about Med Twitter earlier because it's a great resource. Use people do tutorials for journal clubs. And so you get to see sometimes the author of a journal article sort of go through the high points of the paper and how they came to that conclusion. You get to see people do presentations that you would never get a chance to see because they're from Harvard or Brigham or, Columbia or wherever. So these are sort of, great opportunities. Even small things like people like Instagram lives. I'm in a group called Women in Endoscopy, and we're able to do conversations that, just residents and fellows had asked us about how did you do X? How did you get into this? And it's just a fun conversation. It sort of breaks that barrier of people thinking, once somebody's a physician, you can't talk to them. And you find people that are like you and you reach out and they can put you in touch with people in your area. So these are things that are really, really nice about the times now that weren't available before. Just having so much information sort of at your fingertips, you're able to see all these medical student threads where they talk about sort of things that are happening in medical school, things, how to do X or Y. And so these are really good resources to pay attention to. And also just reading as much as you can. The more you read, the more you pay attention, the more you'll make sure there's something you want to do and that you're going into the right field as well. And no pun intended, but also just listening to your gut. You're not putting that thing away. People told me, oh, you should do dermatology. It will be great. I hated skin and I tried to make myself love it, but it was horrible looking at rashes. I just didn't like it. And so these are things you have to know about yourself. What do you like? And people can say, oh my God, you just chose to do gastroenterology and you said skin is gross. Yes, I get how weird that sounds, but you have to definitely listen to sort of what works for you and what's going to sort of pique your interest and keep you sort of happy. And I think that is it from my end. And I think we'll do questions now. I think, should I stop my share so that you can get on here?
Definitely. You can go ahead and stop your share.
Okay.
Thank you so much for that amazing presentation, especially the videos and explaining the videos. Thank you so much for that. I'm sure we all enjoyed that. So some of the questions we've had for our students are regarding some of the videos you showed us. An audience member asks, what are the risk factors for developing polyps in regards to age? So they're asking, do adults have polyps more often than
That is
children?
a very, very good question that's come about recently, and they may have seen this recently. So it used to be a thought that people, the older you got more polyps, and that's why the age for screening for colonoscopies was age 50. And over about the last 15 years or so, we started to see younger and younger people start to have polyps. And the question was, why is this happening? And so one of the thought processes behind that is sort of dietary changes. And there's a lot of new research about microbiome and sort of how what you eat changes your microbiome and changes your environment and gives you a propensity for more polyps. Typically in younger patients, we would find those patients with polyps because they have some sort of genetic predisposition, like Lich syndrome or what's called a polyposis syndrome in their family. And so we screen those people earlier and they get colonoscopies far more frequently. But now the age has been, because we've been seeing so many more younger patients with colon cancer, that age has recently been dropped lower. So recently to age 45, and it was just 45 for African Americans, but now it's been decreased to 45 for everyone. But also still even lower for people who have a family history of colon cancer. So if you have a first degree relative with a history of colon cancer, you would have your first colonoscopy 10 years prior to the youngest age of onset with that person. So if you had a family member, your sister, that had a colon cancer at 45, your first colonoscopy would be at 35. And so it's very important to, talk to people about talking to your families about diseases. I know a lot of people that sort of in certain cultures, you just don't speak about that, but it's really, really important for your screening and for your health, for patients, for people to really talk about family history. Because polyps are a big deal, and they turn into cancers. And as you saw with those videos, they're very easy to take out. It's a very easy procedure. It's like, it can easily do 17, 18 in a day. It's like a factory, and taking out polyps, and, an easy breezy thing that, saves your life.
Thank you for that answer. I'm glad that there's some research on that, just to expand on the knowledge that we have. So Lauren asks, do you perform gastric bypass and gastric sleeve procedures, or do you collaborate with other colleagues? Like, how do you go about
Yeah.
with those?
So what they're asking about are surgical approaches. And so those are done by what's called laparoscopy. So that is with an incision. So they use smaller incisions, but it's still having a surgical procedure. And so that's what a gastric bypass and a gastric sleeve. What I do as a gastroenterologist is by endoscopy. So no incisions on the outside like you would get in surgery. And so not a gastric bypass or a gastric sleeve, but just the endoscopic sleeve where you're suturing the stomach from the inside, or the balloons. There's no manipulation of the small intestines like you get with a surgical Roux-en-Y or gastric bypass. So those are the differences. A surgical sleeve is still cutting through incisions on the abdomen to go inside and manipulating and permanently cutting off like the part of the stomach, like that's called the gastric body. Or it's not permanent, it can be reversed, but the gastric sleeve can be reversed. Not the gastric sleeve, the gastric bypass can be reversed. And that's when they make a small pouch in the stomach, and then they take a part of your intestines and quite literally bypass it. And so they make another incision down lower and bring the top part up. So you're missing a large port of absorption. That's how people get weight loss. So those are they're different. And so what I do is the intermediate for people who don't want that surgical approach and they don't want incisions and are afraid of sort of the permanence of those. And so mine is sort of that intermediate incisionless procedure. And so for patients who need a lot of weight loss, I tend to work with my bariatric surgery colleagues to say, maybe we should, collaborate, and you should see them in clinic, and we can kind of discuss what works best, and whether they would get enough weight loss with sort of my procedure versus a surgical procedure where you tend to get more weight loss.
Thank you for that explanation. So I see that Sophia has her hand raised. You can go ahead and mute and ask your question, Sophia.
Hi, I just have, I think it's a quick question. I was let in the waiting room, let out of the waiting room a little bit later. So you may have already mentioned it. I might just have missed it. But you mentioned when you're getting rid of polyps, you had, and I'm forgetting the name of it, but the lasso technique.
Mm-hmm.
And then the other one you mentioned was that you can inject it with water, or you can cauterize it.
Mm-hmm.
How would you go about doing that?
Yeah. So that's so cool. And so on the scope, you have different little channels that you can put devices through that helps. Like we put that snare, which is the lasso. And so there's other methods as well. And so we also can basically plug those up to like another source, an energy source. That's where the cautery comes from. And we also have injectors with needles. And so we're able to inject epinephrine and sort of something to raise the mucosa. Sometimes there's a really large polyp that sort of spreads across the colon, and you can't really tell what's normal tissue versus what's polyp. And that's why we use the technique to raise things. And that's sort of to move it away from the bottom of the mucosa so you don't cause a complication, like by putting a hole in the colon, but also so you can sort of see which is the polyp and which is the normal. And that allows you to be in. So that's why we use that raise technique. You don't need it all the time, like the pictures I showed you, because they're easier to see. So for bigger polyps, we use the raised techniques. And for polyps that are also bigger as well, we'll use the cautery, because if you use the technique I showed in the video, which is a cold snare, you can have a lot of bleeding. And so with the cautery, it's sort of a similar thing to lasso, but it's just connected to an energy source. So we're able to sort of press on a little pedal that's in the room as we ask our technician to close that, and we just burn right through it, and it comes off just like the one you saw in the video. And if it's really big, we have to use a different device to sort of take it out of the colon. And sometimes we can just suction it up through the actual channel of the scope. And that's how we collect it and send it to the pathologist. And that's how the pathologist tells us exactly what type of polyp it is. So we're able to give the patient an understanding of if it's a precancerous polyp or which is, could have become a cancer, or whether it's a benign tissue.
Great, thank you.
Yeah.
So I see Kevin has his hand raised. So Kevin, you can go ahead and unmute and ask your question.
Right, great. I really enjoyed this presentation. Thank you very much. I have a quick question about the polyps. I was wondering how often they sort of grow back. Does that happen?
Yeah, so that's a good question. And so when we think of polyps, it's not necessarily that polyp is growing back, but what happens is you can create polyps in other locations. And some of the things that we know put patients at risk for polyps are sort of family history. So if you have a family history of polyps, or if you have polyps, you have a propensity of more polyps in the future. Other things are dietary changes. So we know the World Health Organization has listed certain things to be carcinogenic and precancerous. So people that eat a lot of pork, a lot of processed foods like bacon and sausage, smoking also increases your risk. So I try to get my patients off of processed foods like deli meats, bacon, sausage, all those sorts of things, because they increase people's risk for polyp formation. So to continue to have to keep coming back. And so when we talked about taking that polyp out in order to send it to the pathologist, the reason that's important because it lets us know exactly what type of polyp it is. So we can tell a patient what their risk is for having new polyps in the future and when they need to come back. So like I was saying earlier, if it's a person with no family history, no history of polyps in their prior colonoscopy, they're able to only have infrequent screening because we know they're less likely to have more polyps. They would have to be able to come back in 10 years. Whereas if it's a person that has a history of polyps, let's say they had 3 or 4 polyps, depending on the size and sort of what that pathology showed, we would probably tell them to come back within 3 years instead of that 10 years, because we know you have a greater risk of having polyps much sooner. So if you waited 10 years, you probably have a cancer at that time. So that's why we use that pathology. And it's really important for us to get that tissue and send it to the pathologist, because it's really a marker in telling us when we need to have patients to come back to make sure they don't get cancer. Because once you have those polyps, you are at risk for more.
Thank you.
Yeah.
Awesome. So another question about some of the procedures you've shown. Sam asks, what happens when the balloon deflates? How does that affect the patient? Does the patient go back to having like large portion sizes, or how does it kind of affect their lifestyle after they've had the balloon deflated from a few months?
So that's one of the things that we're doing during the 6 months when those patients have the balloon is placed, is teaching them about portion control, teaching them about satiety, teaching them how to manipulate their diet so that they are able to keep that same sort of eating habits when the balloon is gone. And so we're talking them through it. And often I will put patients on a pharmacologic medication to sort of be a bridge with taking that balloon out so they don't go back to eating the exact same way. But usually they don't need it for long, but you could go back if it was done. And some people have this done without having sort of done enough sort of work on the inside, understanding that none of this is magical. The same way people regain weight after they've had a gastric bypass or a gastric sleeve, I tell my patients all the time, nothing is magical. It also is always going to require a little bit of work and a mental change and a change in sort of your attitude surrounding food. And so we talk to people about sort of manipulating certain things to make you feel more full, like having meals that are higher in fiber, higher in plant-based proteins, are things that make you feel more full. So you tend to need less. And so there's just certain tricks that we teach people during those initial 6 months with the balloon in place that help it so they are able to kind of keep that same sort of mentality after the balloon has been removed. And since it's not covered by insurance, they're also invested sort of financially as well. So they tend to want to continue to follow the sort of the trajectory, and they like the weight loss. So at that point, they're very happy and they want to kind of keep things going. And so that's sort of what we use. But you're absolutely right. When any of these procedures, whether surgical or by endoscopy, they can always have weight regain.
Awesome. Thank you for that answer.
Mhm.
Trung asks, what are the advantages and disadvantages of Locum's tenons?
Oh, wow, that's a good one. So I will say sort of disadvantages would be is looked down upon sort of by academic physicians, for sure. It was as if I was killing, the grandmother of the chair of my department, that how dare I turn down, this, to go and staying at this academic institution, to go and do this thing that was seen as, lesser. But so I think that's why I say listening to yourself. And so I knew I had a plan, and I know, but a full-time academic position, I would not be able to take time off to do nutrition fellowship, take time off to be able to go to Madrid for 6 months, take time off to be able to attend conferences, to be able to sit for bariatric obesity medicine boards and nutrition boards. And these are things that I knew were important to sort of what I saw myself doing down the line. So I think that's the disadvantage, is that, you have to have some thick skin, because people really will they feel like they've invested so much in you, which I get during your fellowship, that they think it's sort of a waste of your talent in a sense. Unless but having a plan is sort of a big part of it. I think the advantages are plentiful, which, and I had a friend that had done it before, after being at a job that he hated for 3 years, where he had signed a contract and was just miserable. And it wasn't, at all what it was sort of sold to be, which sometimes you don't know what you're getting into when you don't know what to ask. So I think the advantages are being able to see several different ways of doing things, especially for me. I've been at Georgetown for 6 years. I hadn't been anywhere else. That's the only way that I knew how the world worked, was by the way that Georgetown did it. So it was very nice to see how different hospital systems worked, and things that were better, and things that I didn't quite like. It's nice to be able to have, for me, I was able to get that confidence to be able to ask for what I wanted. As a minority sometimes, and as a woman, sometimes that you feel weird about asking for what you think you're worth or due, as far as how much you work, your vacation, your administrative time, your salary, your time off. All of these things are things that I think you're less likely to sort of ask for when you're fresh out of fellowship. And so if people know that, they know that you're just excited to finally be getting a job. So they know that that's a little bit of a leverage there. But after being during locums, I've seen so many places, I've had that sort of, you're able to get a lot of experience in a short period of time, because you're able to see so many different places. So that part is nice. And you get to pick your own schedule. So my first year out, I published 4 papers. I was off for Thanksgiving and Christmas, which is unheard of. And once you guys go to residency and fellowship and the new year, because I was able to say when I was willing to work and when I wasn't. And I was able to have enough free time to take those 3 board exams in 1 year, to publish all those papers. And I published more than my friends there at academic centers, who are supposed to be, the brains, right? So I think there's many advantages, and I don't think very many disadvantages, unless you don't pay attention to sort of where you end up. And I had a very good experience, because I was very sort of focused on where I wanted to be and what I was willing to and what I wasn't willing to do. So I think the biggest disadvantage, I think, is how people view it, which is, if you consider that a huge disadvantage. So, but I think now it doesn't, it hasn't affected my career in any way. It was people saying, wow, you really thought this out, of how you wanted to sort of craft your career and craft your practice and your business. So I think it's nice if you don't know where you want to be and you're not sure, academic versus private practice versus some type of hybrid model.
Thank you for that answer. Again, awesome answers. Jaden has her hand raised. Jaden, you can go ahead and unmute.
Thank you. I've enjoyed this presentation so much. I actually had a few questions. So you had mentioned that during your fellowship, you learned a lot about nutrition that you wished that you had learned earlier, perhaps med school even. I guess I'm wondering if you had any resources that you've found particularly helpful, or even like what the textbook you're currently working on editing is going to be.
Yeah, you're right. It was during my GI, I never got any of this, even in gastroenterology training, and most don't. So it's sort of sad that I felt like I wasn't helping people very much. But the textbook we're doing is sort of nutrition for the practicing gastroenterologist. And only one last chapter I have to edit, but that'll be the last one before the publisher gets to sort of stamp it and we start to get it out. But yeah, it's sort of from A to Z, and I think that's a good resource. There's other sort of conferences and things that you can follow online too. One of them is Aspen, American Society Parenteral and Enteral Nutrition. There's ASN, which is the American Society of Nutrition. There's lifestyle medicine programs. There's the ABOM, which is the American Board of Obesity Medicine. And even just sort of, like I said, getting on Twitter and Instagram, there's always people, we're always posting about when we have talks coming up, always posting when there's a new sort of lecture that's coming out that everybody can sign up for. So those are really good ways to sort of see the new things that are sort of happening and sort of coming out down the line.
Awesome, thank you. And then I was wondering as well, so you had mentioned you got quite a few additional certifications besides just the internal medicine. And I was wondering how and when you decided you wanted to work specifically with patients interested in weight loss, and when you decided you wanted to become certified in obesity specifically.
Yeah. So let's see, that started so during your fellowship, you go to a first year fellows course and a second year fellows course. And it just happened to be that I got lucky. And one of the presenters during the second year fellows course is a guy, Christopher Thomas at Brigham and Women's. And he started this bariatric program about 10 years ago. And it's still, like I said, a very new field. And so when he presented about this stuff and showing these videos, I'm like, no one has ever told me. I've never seen this stuff before. This is amazing. I want to do this. And so, like, there's another thing I say, be curious and ask questions and don't be afraid. And so I went up to him after his talk and said, hey, I want to do this. How can I do it? How in the world did you start this craziness? And can I come to Brigham? And he said, sure, come to Brigham. That'll be fine. And then, of course, you can do this conference that's coming up in Illinois. Turns out when I got there, I was the only fellow and everybody else wasn't attending. So it was a little weird, but did that program, learned a bunch there. And then I was in sort of that crew of people who did bariatric endoscopy, which set me up to be able to go to Madrid and to be able to be in those spaces to sort of get more education, to do more research papers. And when I realized I wanted to do the bariatric endoscopy piece, for me, it didn't feel authentic to be able to do one piece, not the other. And I felt like that's why a lot of patients didn't have a lot of success. It's because they didn't have a physician that was able to talk to them about nutrition. And so I wanted to be able to give patients the entire depth of sort of knowledge, which was the nutrition piece, the obesity medicine piece, which is knowing how to speak to patients with excess weight, making them feel comfortable so they don't feel like somebody's judging them and having a lot of bias. And to be able to sort of break through sort of that wall that is sort of put up a lot of the times. And also being able to do that pharmacotherapy piece, which I think is missing, and understanding which medications are weight positive, so you can change them to weight neutral medications. And there's certain just small things about, sleep, microbiome, meditation, so many other things that sort of contribute to weight gain. And so these are all things I learned with, through my obesity medicine training. And so I thought that was a missing piece that sometimes surgeons don't have. You go in, cut, and they're done, and patients regain the weight. And so I wanted to be able to educate patients on the other consequences of excess weight with cancers and cardiovascular disease and, musculoskeletal disease, cerebral vascular disease. So it really affects sort of every part of the body. And so it started sort of, probably started my entire life, which is weird. And I look back about sort of my family and making me learn about, gardens and that sort of thing and not being able to have certain things. But so it probably was more ingrained in there than I realized. But definitely during my fellowship, when I realized that I am not helping people in a sustainable way with just doing procedures and not being able to counsel them well on their nutritional needs. So that fellowship, sort of that going to that presentation, and being able to hear his talk about that sort of procedural piece was sort of what drove me to say, okay, I definitely do the procedural piece, but I can't do that without that middle kind of sauce to be able to kind of make the entire thing work. So that was where it all came from.
That's absolutely wonderful, especially given how big of an issue obesity is in the US nowadays, and how
Yeah.
difficult, how many people do experience like weight regain after procedure, like after pretty extreme procedures.
Mm-hmm.
And I've read a lot about people who have issues with weight just feeling uncomfortable even talking to a physician about it a lot of the time because of what you were mentioning, like with regards of not knowing how to talk about it in a way that makes the patient feel comfortable. So that's absolutely amazing.
Yeah.
And
And
then
a lot of it, not understanding the pathophysiology of obesity too, because the old way of thinking is, oh, you put too much food in, you're not moving enough. And it's a little bit more complicated than that. And so being able to understand that and learn that and explain that to patients too, it's really helpful because they already feel bad enough. They've been judged their entire lives. They judge themselves. And you go to the doctor and they tell you at the end of every visit to lose weight, but no one helps you with how. And if that were easy, everybody would do it. And so it's not really just that simple. So, kind of giving them that space to sort of, and telling them that it's really not that simple. You really do need a little bit of help, and it's not okay to sometimes need pharmacologic therapy to help with your basal metabolic rate. And I explain it to them as the same as the fact that if I walk outside in DC here with all of the pollen without taking allergy medicine, it's the same thing. It's not like, you're deficient. I'm deficient in histamine, same thing. So we all need a little bit of help, and it's not, not a sort of a knock on you when people need help. So I think that's the fun part. That's why I wanted to make this practice and make it comfortable. So people, they always say when they come in, it feels like a spa in here. I'm like, that was very intentional. I want you to feel relaxed. I want it to feel, you to feel comfortable. And, we joke that it's a safe zone that people can say whatever they want. So, and I think that's what we have to all sort of move through. And I think we're getting there.
That's so wonderful. And I just had one final question, which is that so I have a friend who's been talking about wanting to get gastric sleeve procedure as well. And he talks a lot about how having been obese for a very long time, it's very difficult to do exercise. And I was wondering how much you talk to patients about the exercise component, how that might change as like their weight changes and things like that.
And I also feel you hear this all the time, and you feel so bad for people because they're so conditioned to believe it's because I'm not working out enough. And so I talk to patients in the beginning, I don't even want you to try to work out in the beginning. You're going to have musculoskeletal pain. You're not going to be able to have that same drive to work out. And the fact of the matter is, in the beginning, exercise is great for general overall health. It's also great for weight maintenance, but it's not going to, my joke is you can't outrun a bad diet. And you can't eat a dozen of donuts and go work out for 2 hours and think those things cancel out. They don't. It's just not going to happen. And so I think that's one of the things that sort of a misconception that is put out there, that if you just work out enough, you can lose all of this weight. But I'll say 75% of it is what we're eating. And it's so many small things that I do in clinic when we talk about even like labels and types of foods that, marketing companies do a really good job at marketing things that are healthy on the packaging. But I get people to just turn that around a bit and let's just see what's, the 25 different ingredients are in this healthy food. A healthy food doesn't need 25 ingredients. An apple doesn't have I have a thing on my thing, the nutritional label on an apple is like fiber. You don't need a label for that. So I think a sleeve is maybe a good idea for him, but making sure that, he understands that it's, a long-term thing. They make sure it's good nutritionist and understand it's going to be sort of a lifestyle sort of change and not a diet, and it's not magical because they can regain. And so it's really, once the weight starts to come off, you have far more energy and you're able to do far more exercise. And that's really important for keeping it off, but not for necessarily losing.
I see. Thank you so much.
Yeah.
Thank you for those answers, and thank you, Jaden, for your questions. We have another question from an audience member asking about weight management that isn't related to diet, but more of medication. So they're asking about the experiences they've had with like psychotropic drugs and how it increases their weight, and just how do you deal with patients in that kind of field?
Yeah. So I work really closely with psychiatrists, with the patient psychiatrist or internal medicine physician, whoever started them on this medication. That is a major one when patients are put on certain, especially antipsychotics. There's some depressive medications that cause a lot of weight gain. But the nice thing is there's so many options now that there are weight neutral sort of medications. However, I don't want to tinker with people's things without talking to their psychiatrist first and making sure they're appropriately sort of titrated and added on the first one to make sure there's no other side effects or contraindications, because that is a major barrier to weight loss in a lot of my patients. So yes, we work very hard on sort of working together and having a collaborative effort and sometimes they've already tried some of those weight neutral medications. That's how they ended up on those. And sometimes people just aren't really, they don't think about that. They just think about, oh, well, I fixed your bipolar disorder or I fixed your schizophrenia, you should be happy. But now you've caused another sort of another distortion, another problem, and the anxiety and the depression surrounded with weight gain and the social stigma that you get and people looking at you and staring at you and saying things about you. You feeling just uncomfortable in your clothes or even in chairs in an office. Any of those things, cause people to have a lot of distress. And sometimes those are just things that we as physicians, don't think about, which is why we're doing more of these lectures and kind of doing these things for our fellows as well. So people start to think about it a little bit more. So it becomes one of those things that you don't just cavalierly prescribe. And so just making sure if you see a patient that has problem with weight already, putting them on a Geodon or something like that is not going to be their best friend. They're going to gain a significant amount of weight and that can also contribute to their anxiety and depression. So I have to be aware that as well as gastroenterologists, because I prescribe a lot of steroids sometimes for short periods. And I warn people this can make you gain weight. And so I think it's, so people are aware that this makes you more hungry. So not to sort of try not to give in to that thing that makes you hungry and say, this is the medication, I'm not actually hungry. It can make people have insomnia. So it's just, a matter of talking to people about sort of side effects of medications that aren't necessarily life-threatening, but they really change your way of living. When people gain 30 pounds from being on the medication, that's a pretty big deal.
Thank you for that answer. Another question that we had was, how does the balloon affect the absorption of vitamin B12? Junior asked if it can cause anemia.
No, it does not affect the absorption of B12. You have a couple other things that happen with your R factor that also comes from the stomach that's able to attach in the acid that's also produced to break that a piece. So you get intrinsic factor. So you're able to absorb your B12 well. So yeah, that one is not one that gets the balloon or the endoscopic sleeve. Neither of them really affect your absorption. The one that does is the surgical gastric bypass. So because you're bypassing the first part of the small bowel, and so you don't get very good absorption of iron, vitamin D, or B12 in some cases as well. So we always, and B1, thiamine. So we make sure that patients, especially if you start to notice, oh, they having drier skin or they're anemic, but their iron is normal. These are things that you have to think about a little bit to sort of get to the bottom of what's going on. And then you've realized, oh, the patient's not taking their vitamins anymore. They thought they didn't have to take them. Even they're like, oh, I had that surgery 10 years ago. I really still have to take it. Yes, you still have the anatomy of a gastric bypass. So that happens pretty frequently. But the intragastric balloon or the endoscopic sleeve, there's no interference with sort of absorption because we're not rearranging sort of how nutrients are being absorbed.
Thank you for that answer. Another question that we've had is, how do you deal with patients who live in areas or who have a socioeconomic status in which they can't afford to eat like nutrient-rich foods, or patients who've grown up with a culture that maybe their parents were impoverished and they weren't able to eat nutrient-rich foods and they just grew up with processed foods?
Yeah, it's actually very common, especially in DC. There's areas that are definitely food deserts. And so I talk to my patients as well about even getting frozen foods. So a frozen vegetable or frozen, they're as cheap as sort of a canned vegetable. Or when I talk to patients about sort of cost analysis and we look at sort of a Pop-Tart. And so it tends to be when you change people's frame of work, they don't think about these foods anymore because a bag of beans is usually about $1.20. But people don't, in that bag of beans, you're not gonna, one cup will last you an entire week. That's gonna make a lot of beans, or a bag of quinoa, or a bag of, whatever. Those things are very cheap. But people don't think about those things. They think about, oh my God, it's going to be too expensive to eat healthy, which is sort of the narrative that's really put out there by these marketing companies, which is a little bit unfortunate, because Pop-Tarts cost $3 or $4, and you have like 4 in a box, and they're crap food, and you're going to be hungry within 5 minutes afterwards. But it's marketed as, oh, well, look, that's cheap. Or, ramen noodles, they are cheap, but your sodium and your blood pressure is going to go through the roof. But if you are able, when we're able to sort of if you get a bag of frozen broccoli, a bag of spinach, a bag of frozen green beans, you've spent $4, because those are all you can get from Walmart or any other grocery stores around for. Usually they're on sale with the store brand $1 a bag, and they're going to have about maybe how many, like 20 to maybe 100 grams of sodium, whereas the sodium on the back of that canned food that people think of as cheap and better for them, those cans can usually get about $1.50 a piece. So it's more, and you're going to only get 1 serving out of that can. Whereas with the frozen vegetables, you get far more servings. And with that can, you're going to have, 500 milligrams of sodium. So those are things that we talk about with our patients. And I show them actually labels and are, these things that are sold as healthy, like lean cuisines and all these sort of things. I show them the back of a lean cuisine that's a veggie lean cuisine, and the back of a box of just spinach or just whatever that's in there. And they start to see, oh, that's a major, major difference. So we definitely go through sort of labeling and those sort of things. And there's always cheap options for a lot of, especially frozen foods or whole real grains that come sort of in the bag. And they're not difficult to cook either. The bag of beans, you put them in some water, you go and do your business. You set a timer, you go back to check on them, but they'll take a little bit to cook, but cheap, last for the entire week. That way you're meal prepped for the week, and sort of they're easy to sort of have for the entire family.
Thank you for that answer. I think it's just all about understanding your patients and seeing what they'll understand and convince them at that level. So thank you for that. Ella had a question. She says that I had never heard of a nutrition fellowship before. So she's asking if nutrition fellowships are paired with specialties besides gastroenterology, or is it just the only specialty?
Yeah, so there are, and you're right, there are a few now, and they're not just with GI. So in my nutrition fellowship that I did, there was critical care, there was a surgery resident as well. And so there was critical care, surgery, a couple of GI, and then an internal medicine. So any field, nutrition applies to sort of every field. So no matter what field you are, you should have a little bit of an understanding about sort of nutrition. So yeah, many of them don't require that you be within a specialty.
Okay, for the last question, I just wanted to ask if you've had any last advice for our future gastroenterologists and pre-health students here.
It is the best field, let me tell you. You should totally do it. They tell you that if you're a woman, oh my God, not enough women in GI, not enough minorities in GI. If you are a woman or minority, definitely do it. Representation 100% matters. People like to see people that look like them. Makes them far more comfortable. That's one thing I would say is sort of reach out. There's tons of sort of groups, like I said, on Twitter, on Instagram, that you can join to see like more of those cool videos. One of them is on Instagram, is ASGE, to see more videos, to sort of see if you are like, something that may pique your interest. So I think, there's so many opportunities to learn so much more just at your fingertips now. Like just while you're scrolling, it's super easy to see some of these things. So I think that would be my advice is do it. Like, reach out, do research, get involved, and kind of keep your eyes open to see what you may like. GI isn't dirty. It's not like the gross poopy specialty, even though we joke about poop all the time, but it's really a cool, as you saw, it's so many different things you can do within GI. It's a huge specialty with a bunch of subspecialties even within it. So it's fun.
Yeah, I think you've definitely convinced some of our students to join GI with
Yes.
your awesome presentation. Awesome. So speaking of that, thank you so much for that informative presentation. I'll just go over a quick wrap-up presentation for you all. We learned a lot from our speaker, and considering this, we would like to encourage everyone to reflect on the session today. So what brought you to the session today? What are 3 major takeaways you got? And what do you want to learn more about after the session? This is not required, but it's just a little reflection to document your thoughts and feelings during the presentation. And if you wanted to write something cohesive and maybe have it published, you can definitely do that at our website, at www.prehealthshadowing.com/blog submissions, and you can submit articles, reflections, reviews, and success stories to us. I'm the editor-in-chief, and I would really love to read some of your submissions. So this can enhance your future applications and just be like a little documentation of your experience here with us at PHS. So if you want to learn more about pre-health shadowing and get involved in our program, we encourage you to visit our website. You can become an asynchronous volunteer to get certified hours through professional nominations, graphic design, and social media promotion. We are also accepting team member applications if you'd like to take on a more active role and lead groups of volunteers, lead projects, and collaborate with other team members and have different initiatives. So it's a lot of fun stuff. If you'd like to join, make sure you look at the links in the chat. Once again, we are humbly asking that if you are financially able to, please donate, and please considering sending a few dollars to us via Venmo or PayPal. It does cost a lot for us to keep our program running and our website up. So if you are able to or know someone who can, please consider donating. If not, we simply ask everyone to spread the word about pre-health shadowing, maybe telling your friends about us or sharing one of our posts with your social media accounts, just to reach as many students as possible so everyone knows about our program and can join on our Zoom sessions. So now for the part we've all been waiting for, how to earn a digital certificate which verifies your virtual shadowing hours with Dr. Laster today. So first you will be going onto our website and finding our professionals course pages. You just simply search for their name and it will pop up at prehealthshadowing.com. Then you are able to take our quick 10-question multiple choice quiz based on the content from the session today. So once you open the quiz, you will have 30 minutes per attempt, and you must earn a 70% or higher, which is 7 out of 10 questions correct. You will earn your certificate after that. We know that sometimes technology can be difficult or you might make a mistake. So we do allow 2 attempts. Once you open the quiz, you have 30 minutes, but you have 2 attempts to take it. The quiz is open indefinitely, so you're able to take it tonight, tomorrow, next week, next month. It's up to you, but you have 2 attempts once you open it. Once you have passed, you can click the Finish Course button at the bottom of the professionals page and download your certificate verifying your virtual shadowing hours. If you happen to miss a part of the session or just want to refresh your mind and look at the other sessions we've had in the past, you can go to our YouTube channel, Pre-Health Shadowing, and view our recordings there. We also have our recordings via the professional pages on our website, so you can view them through our YouTube channel or the professional pages and take the post-shadowing assessments for any of the sessions in the past if you find them useful or interesting. Be sure to follow us on social media and subscribe to our email list so you never miss a shadowing session. We are currently booked every weekday until June for virtual shadowing sessions, and we will continue to have more sessions after June. So I hope to see you guys there, and please keep up to date with our email list and just social media. We post when our sessions are going to be at our email list and our Instagram. So thank you so much for joining us today, and please stick around if you have any questions for myself and other team members. We will be happy to answer them. This shadowing session is officially over. Thank you so much, Dr. Laster, for being here. Thank you to the students who asked questions. Have a wonderful day, and I invite you all to log off.
Thank you guys. Have a good night.
Have a good night. Bye.